Welcome back to the Dr. Beau Show. I am Dr. Beau Beard here at the farm in Birmingham, Alabama. And today we are talking about chiropractic. Really, we should get outside of the chiropractic realm. Treatment plans when it comes to conservative musculoskeletal care. And again, we could go outside of that realm too, but let's stay where in the sandbox that I play in. This is not something new that, kind of pushes my buttons or is, what was Peter's last name? What's Peter's last name off of Family Guy? Doesn't matter. Whatever grinds his gears, right? He got his own segment on the local news show. But what grinds my gears are these treatment plans that have, for the longest time, been normal within the chiropractic profession, becoming not so normal, or at least looked upon with not such a good taste in people's mouths when they realize that, hey, there's people out there that are getting people truly better in much less time, and also an amount of time that's backed up by evidence. So let's talk about what would be deemed an efficacious, time-effective, cost-effective treatment plan. So a treatment plan defined would be the plan for your treatment. How many visits, how often, how much it's going to cost, maybe as part of that if you want to try to sell somebody up front. But a treatment plan typically, or a trial of care would typically be anywhere between 4 to 6 visits. You could extend that out for sure. I would say upwards of 10 visits, depending on what you're working with, who you're working with, consistency, adherence to drills and homework, things like that. But 4 to 6 visits over a framework of 2 to 3 weeks gives you a lot of therapeutic input, but also a lot of diagnostic feedback. So I always tell our patients that if you go home and do the things that I've taught you to do and ask you to do, and we've provided good materials, which we think that we use our app and videos and explanations, education, empowerment, all to get the patient into the best position possible to then have the greatest chance for success possible. If they do that homework, there's 2 things that happen. It's like a choose your own story. They get better, and then we move forward, right? And that, I call this a confidence interval. So a confidence interval would tell us how confident are we that we're sensitive and specific to the thing that we're working with. So my confidence interval when anybody leaves the office is going to be about 95% after that first visit. Why isn't it higher? Because we're dealing with humans. Humans are complex. They're also maybe not super compliant. There's a lot of things going on. My confidence interval should be around 98 to 99% after the second or third visit, because I've had time to get feedback from this person based on the things they're doing, their environment, the homework we send them home with, a lot of things. If we're not hitting that 98 to 99% confidence interval within that time frame, that within that 4 to 6 visit window, that means what? We have the option for imaging, advanced imaging, referral, other conservative means, depending on what we're dealing with, right? Pain management, things like that. But when we get these long-term upfront treatment plans, it begs the first question: how in the hell do you know that somebody needs to come see you for 9 months for this malady that you're not even confident what it is, especially based on the examination criteria that we're going to explore today? So let's jump into this thing. And I don't want to pick on my colleagues that much, but you have to sometimes, because times change, information changes. We're in a humanitarian based service industry, right? Yeah, we're physicians, and some people may argue with that. We're chiropractors, right? We're here to treat people. Well, if you're here to treat people, are you really here to do the best thing for them? You're here to pad your pocketbook. Because if you're really good at treating people, you will make a lot of money. If you're really good at making money, you'll eventually not be so good at treating people because you're so damn busy seeing people every 3 minutes and doing what's going on here. So I've blacked out all the pertinent information on this treatment plan that was given to us by a patient that we saw after they saw somebody else for a couple of visits. I'm not going to get into the details too much because I don't want to give anything away. But again, pertinents are out of here. But I just want to, I'm going to show you and then I'll read. So it says, subluxation and health findings prepared especially for the patient. And then it says, our recommendations have been prepared with the utmost care and will be of the most value when followed. I agree, right? We send people home with homework. Keep this report with other important papers, as we will be providing additional information beneficial to your health. Okay, good. All right. So this first thing is a picture against a posture screen, which is basically just a dashboard. It's a graphed dashboard where we're looking at just cervical posture. I'm not even going to tell you what this patient's main complaint was until the end of the video. It's just such a cliffhanger. It's so good. But it's a posture screen. What's interesting is this posture screen picture, whether the information is supposed to match or not, I'm not showing you the picture because I don't want to show you who this is a profile picture. Somebody looking to the side, and it says weight distribution 2 pounds heavier on the right. Why is the picture from the side? Again, this could be information that's not correlated. It just doesn't make sense to me right off the get-go. And then it says, for example, 0.95 inches forward equals 9.5 pounds extra head weight. This is, the bullshit piece here is, does the extra head weight matter? No, people have proven this. Posture isn't a direct correlate to pain. Does posture matter? Yes, it does. But you can't say things like 0.95 inches forward equals 9.5 extra head weight, because it doesn't matter. Because guess what? You compensate, you adapt. We're humans. That's why we're here, because we're the most adaptable organism the earth has ever seen. That's why we're at the point we are as an apex organism on the earth, because we're adaptable. If we couldn't adapt to holding our head a little bit forward, which we've been doing for years, think about an ancient North American native making a obsidian-based arrowhead or spearhead. Do you know how long that would take? Do you have any idea how long that would take? A long time, right? With the tools at hand, with other rocks to chip away at obsidian or flint or whatever we're working with to make, these arrowheads or spearheads in particular. What position do you think they were in? Do you think they were doing it like this? Perfect posture with not the 0.95 inches forward? No, they were in a flex posture. Now they may have been in a squat. Maybe that's better than a chair, right? We've been doing this stuff for eons. Now, did they do other things to help offset that? Sure. But do you think they were going to their chiropractor 3 times a week for 12 weeks? No. Let's think where we came from, where we are, and I realize there's a ton of environmental mismatch. I've talked about that numerous times on the show, but let's get smarter than just saying things that seem like they would be right, but actually have no evidence. And speaking of things that have no evidence, let's talk about the neurofuse box, the effects of the subluxation. So if anybody's familiar with what the Merrick chart is, the Merrick chart is a chart that shows how each level of the spine, each vertebral segment is going to be responsible for organ function. This would be based on the fact that vertebral level or segmental level has nerves that are going to be delivering afferent and efferent signals to that part of the body. So let's say, up here it says C4 through C7 is nerve supply to the shoulders, arms, and hands. Yes, it is. ENT system, metabolism. Your whole enteric system is, there's splanchnic nerve. Then we get into things like, possible effects with areas of this. If this is speech challenges, poor metabolism and weight control, I would love to see a peer-reviewed article, because I realize that truly evidence-led medicine is always going to be ahead of the research. But if we've been doing this for over 100 years and we've been running off of, or chiropractic been running off a subluxation-based model for over a century, surely somebody's looked at this, right, with actual evidence and shown, well, if I have a subluxation in the neurofuse box around C4, C7, I actually have poor metabolism and weight control. Come on. But other things, croup and cough, anxiety, I don't know. It gets a little weird, right? T4 through T7, detox and immunity. Come on. Let's see some other good ones. I don't know. Is there something to some of these areas? When you get up into C1, C3, and they're talking about vagus nerve stimulation. Sure. Right? I get it, right? That's vagus nerve, the traveler. It's descending cranial nerve that passes through your whole cervical spine and end up basically around your stomach. Some of this makes sense. Some of it doesn't. But then when we say I'm going to read through this really quick. When a fuse blows in your home, certain areas or appliances may not function until that power is restored. Similarly, by finding and correcting any subluxations in your spine, specific chiropractic adjustments help restore power and function to those parts of your body. I don't want to get completely negative. I'm just picking out stuff that doesn't make sense. Now, here's where we get really far off the deep end. And here's where we got to show you stuff. Let me make sure that this is all good as far as pertinent information. I'm going to black one more thing out here. But when we talk about physicians, I'm going to say practitioners that do before and after comparison x-rays or a lot of x-rays as part of a treatment plan, that's not evidence-based. It's actually probably deleterious, especially if you're dealing with a child, which this is also, I'll just tell you this, it's a 12-year-old female that we, overexposure with radiation for the possibility of seeing some anomaly. Yeah, maybe. Yeah. Like, hey, if you're going to go adjust somebody's C-spine, I think your examination should take care of 99% of that confidence interval thing. But again, I haven't told you what this person's chief complaint is. And we're talking about doing cervical spine x-rays, right? These are not the patient's x-rays. These are the standards of, this is normal with a normal cervical curve. And this says healthy, pain-free, physically fit, stress-free. Because if you have a normal curve in your cervical spine, you're healthy, pain-free, physically fit, stress-free. Because you can have a perfectly normal curve in your spine, eat shitty food, not exercise, have a lot of stress, have bad relationships, have no spiritual connection with anything, never go outside and be healthy, pain-free, physically fit, stress-free. Come on. Phase 1, headaches, neck pain, strain, muscle, shoulder tension. That just happens when your neck straightens out, that you get neck strain. Let's fast forward all the way down to phase 3. Chronic pain, irreversible damage, spine disease. So Dr. Daniel made a really good point with this, hyperkyphotic kind of Dallinger's hump patient. Sorry if you can't see this. They've moved forward 3 intervals. So their head weighs like 189 pounds or something, but irreversible damage. So he made the kind of side note, well, if it's irreversible, why are you treating them as a chiropractor? If it's irreversible, isn't that just wasting their time? There's not going to be any objective outcome measure. This kind of looks like an elderly person. So if they're using Medicare, we have to provide a certain level of notes that show that we're actually having outcome effect. How are you doing that with irreversible damage? I'm curious, right? Okay, so now let's look at this patient's x-rays, right? So let's review this type 1. Let's get this focused, right? Is normal. See that curve? I don't know. That looks pretty normal, right? Looks pretty normal. All right. So I don't know. It says phase of subluxation, degeneration, wear and tear. It's a 1. It's not normal. It's a 1 for sure. For whatever reason. I don't know. It's a 1. And I want everybody to know, I did x-ray marking in school. I learned this stuff. It's not like I'm just like saying, oh, this is crap. All right. We learned this. You put the things that you learn up against the rigors of science, right? Physiology, biomechanics, physics, anatomy. And then you determine, does this jive with those things? Does that make sense, right? That way, when you're learning things, different techniques, modalities, you're a patient, you're being told things, you can apply things back against the principles of science and say, does that actually make sense? Some things are harder to make sense of because the evidence isn't quite there to back it up fully, but the principles don't change, right? Like I was reading an article in Scientific America about looking for supergravity, the new force of physics that will be the ultimate force beyond gravity. Can we base anything on supergravity yet? No. Do we know things aren't quite right based on the laws, which are laws of physics? Yes, we know there's things that don't make sense. We're not there yet. So we can't say, hey, we're going to design a rocket ship with anti-gravity propulsion because we don't understand 100% how gravity works, right? We have really good theories, right? The general theory of relativity. We're getting off course here. Anyways, there's no general theory of spinal subluxation that like stands against the rigors of science. That's all I'm saying here. And we're here to talk about treatment plans, but we got to kind of push holes in this one. We get into lumbar spine, level of phase of subluxation is 1 again. I mean, there's x-rays again. Haven't told you what the chief complaint for this patient is yet. And then I'm not going to show you the last page because there's too much pertinent information, but I'll read. So let's go over, this is a 12-year-old female that had knee pain, diagnosed Osgood-Schlatters pain, right? Tibial tuberosity, pain, tenderness to touch, swollen. We know this because we saw the patient, right? After 3 visits with this practitioner, this chiropractor, this person that likes to take money, whatever you want to call him. So here's the plan, the wellness care plan, because it's a wellness care plan, not an injury relief plan, because that just doesn't make any sense to get a kid out of pain and think that like they'll be okay if we just like normalize, tissue tolerance or, work on mechanics or whatever. So 2 times a week for 8 weeks, you got 16 visits. 1 time a week for 12 weeks, 16 plus 12, we're up to 38. Every 2 weeks thereafter. It just says every 2 weeks thereafter with no end date. So right off the get-go, we're at 44 adjustments is what this is calculated at. And it says investment in your health, $1,980, right? Or you have payment options. So there's a lot of things going on here. So we just found out that, hey, this is a pretty young person. So what do we know about young people in general? Maybe not so much nowadays, but in general, pretty resilient, right? So we got a resilient, this is an athlete, right? It's got knee pain, no other complaints, knee pain. We're basing the treatment on cervical and lumbar spine x-rays, based on a subluxation model, based on care that's going to take, how many weeks have we said now? 8 plus 12, so we're 20 weeks in. Every 2 weeks thereafter to 44 adjustments puts us out. It's 12, 3, so we're at 5, 6. We're at 7 months of care. 7 months. I would like to see the evidence, and maybe I'll pull that up before I post this video, on if we do no treatment on a 12-year-old female with Osgood-Schlatters or just tibial tuberosity, anterior, generalized patellofemoral knee pain, whatever we're going to call it. Maybe we look at all those. How long it would take to go away without treatment while you continue your sport or take time off, either one. I would just be very curious. So there's a lot of issues here, right? This is one of the big arguments within the field of chiropractic and physical therapy and conservative musculoskeletal care, that we use time as our ally too much and that we're providing palliative care, right? Things that make you feel good over a duration of time that then allows the body to actually do what it would have done anyways, right? You just feel a little bit better during that time frame. That's part of it for sure. But I can guarantee you one thing: if you have something such as cervical radiculopathy, and you give somebody 3 to 4 visits and you have a 90% resolution in pain and symptoms, especially radicular symptoms down the arm, I don't think that would have happened on their own without changing something mechanically, offloading a tissue, changing interfaces, changing a strategy. And we do other things in here. Like I said, like I referred somebody out today for a steroid dose pack because something's going on that just doesn't make sense. I may be doing a case study on that, so look for that in an upcoming video. But this type of stuff has to stop because people don't know, like these people didn't know that this isn't in their best interest. They thought, oh, I went to a chiropractor. Oh, I have to sign up for their once a week class to learn why I need to come. Does that not sound like a timeshare? Like, hey, let me give you a free dinner so you sign up for my contract for life that you can never get out of unless you give me 3 pints of blood. Like, I hate, I'm not going to use the word hate. I just can't stand that I'm tied to a profession that is still doing this, right? If we had done this and we moved along as a profession and said, you know what, these long-term treatment plans, especially paying up front, who knows if this person's actually doing what they're supposed to do legally, of putting that money aside in an escrow account and pulling the money out per visit while the patient's being treated. I doubt it, right? It just really gets me up in arms for the profession, but also for that patient, especially when it's a kid. And, if my kid was hurt, I can assume if I didn't know anything about this field, my kid's hurt, somebody tells me they have a plan, it seems rock solid, they're giving me evidence, but I don't understand that it may not be applied to the rigors of science, that then I say, I'll do whatever it takes. I'll pay whatever it takes to get my kid better. And then we're preying upon this. And I know that this practitioner in particular sees a lot of kids. That's why it really just gets to me. And let's say this, the wellness side, people that like to go get adjusted. If you want to go get adjusted every 2 weeks and you don't have an actual issue going on, then you're just spending your own money, right? Because insurance doesn't cover that, first of all. That's wellness. And if insurance is covering you to get adjusted every 2 weeks, then the person you're working with is committing insurance fraud, unless you have wellness care, which is rare these days. But again, it's just, you know, we should do better than that. We should do, you know, the minimum effective dose. If you have to take, you know, if you took 2 ibuprofen to get rid of your headache and you took 10, that doesn't help you. That actually hurts you. Right. So that's the same thing that we should be doing, because we're trying to make it cost and time effective for people, but also educate and empower them that they don't need to rely on us for an adjustment every 2 weeks, which is just, you know, bullshit anyway. So I think we should torch this thing right here on air. No, I'm not going to burn it. I'm in my office. I'll burn my office down. Then I'll be upset that I can't treat people. I just got ash all over me. But that being said, that's what I'd like to do. And if you get a treatment plan like this, you should get your lighter out. You should light that puppy up, burn it, throw it in the trash can, take a picture of it, post on there, hashtag no long-term treatment plans, down with the treatment plans, burn the treatment plans. I don't know. Somebody will come up with a better one than I did. But this is mainly a PSA, a public service announcement. If you get a plan like this, if somebody wants you to show up for their Monday night classes every Monday for 4 weeks, bring your family and friends, which is a marketing tactic, not so your family and friends understand what's going on so they can help you with your process or journey. It's so they can get on the same damn bandwagon and pay $2,000 up front. Who? Peter Griffin. Griffin's his last name, and it grinded his gears. He had his own TV show. Treatment plans grind my gears. And this has been the Dr. Beau Show. See you guys.